good evening. I am thankful for this opportunity because endometriosis is a very, what would I say, a weird topic because nothing is clear, and because of this opportunity I read many new articles and I gained lot of insight. I hope you will also get some clinical points out of this discussion today. Coming to endometriosis, 1 in 10, yes, it is not uncommon. So, at least 1 in 10 women of reproductive age group, they suffer from endometriosis at some point of time. And yes, it badly affects the quality of life, fertility as well as daily functioning. And even our celebrities, they were not spared from endometriosis. So, it is quite common. So, you all know that what is endometriosis, that clinical and theoretical part, but what has changed? Now, endometriosis is not just a pelvic disease or a hormonal component. It is a systemic inflammatory disease with multiple factors like multiomics, immune disorders, genetics, epigenetics. And frankly speaking, as clinician, we are not much aware about the genetics, epigenetics. So, today we will gain some knowledge out of it. And then the term precision medicine, which is quite important in endometriosis, and we will have some knowledge about it. So, as you all know that endometriosis means the tissue which should be inside the uterus, it grows outside the uterine cavity, leading to hormonal changes and biological trauma. So, there is inflammation because of the immune response, scarring, formation of thick fibrous bands leading to all the cascade of severe pain, neurological signaling and structural distortion. So, there is a new proposal that endometriosis, rather a pelvic organ disease, it should be treated and researched as a systemic inflammatory disorder with gynecological expression. So, the pathological cascade is, as we know that it is an inflammatory disorder. So, what happens? The tissue inside the uterus, it sheds during each cycle with typical menstruation. There is abnormal ectopic growth, which is endometrial like tissue, which are attached to ovaries, fallopian tubes and other organs. So, the inflammatory response which happen lead to adhesion and formation of endometriosis. Now, the etiology, from our PG times we are reading it that there are many theories, but of practical significance I think we can explain to the patient in a very layman language the retrograde menstruation theory, that some cells in each cycle, they carry the cells backward through the fallopian tube. So, that causes spread of all endometrial cells in the pelvis, which can lead to immune dysfunction. And recently there is lot of research on genetic component. Yes, endometriosis also has a genetic predisposition. So, there are multiple genes which contribute to susceptibility and more disease severity. So, some people may have more severe disease and some may not. Then there are another additional factors like environmental, early menarche, late menopause, nulliparity, they all cause endometriosis surge. So, many patients, they come to us and they ask that why they are having endometriosis and what is endometriosis. So, to explain to the patient in a normal language, you can just make a diagram of uterus and ovaries grossly and you can tell them that these are the lesions where the ovaries and all the surrounding area, they are covered by the blood. So, it is trapped in the pelvic cavity and it bleeds cyclically. So, basically endometriosis is a silent epidemic with systemic consequences. So, the prevalence, as I already told you, it is around 1 in 10 women. 30 to 50% women, they experience infertility, or you can say the women who are infertile, almost 50% have endometriosis. And the diagnostic delay, really it is 4 to 11 years, and on an average of 7 years before the patient reach the endometriosis specialist for a diagnosis of or a definitive conclusion of endometriosis. So, what is this cost of diagnostic delay? On an average, there is 7 to 10 years of diagnostic delay, which leads to infertility and reproductive impairment. So, there is inflammation and anatomical distortion of the female pelvic organs. Then there is neurological shift, persistent untreated pelvic pain, neuropathic pain, and people are having so much pain that they are being referred to psychologist or psychiatrist for persistent pain, and mostly nobody takes their pain seriously, and some think that they are functional, but that is neuropathic pain which should be dealt properly. And it all causes a psychological toll on the prolonged chronic pain cascade. So, which increases the risk of depression, anxiety, and profound psychological distress. You must have experienced women coming to your clinic or your hospitals with lot of low self-esteem, depression, anxiety because of the non-intervention, or I would say non-diagnosis of endometriosis. So, early intervention is not about symptom relief, it is about the improvement of quality of life, or I would say saving a woman's life. You all know infertility, urinary issues, sometimes they may have cyclic hematuria because of bladder endometriosis, painful urination, urgency, chronic fatigue, exhaustion, which is unrelated to activity, no sleep, bowel symptoms like bloating, painful bowel movements, or pelvic pain and dysmenorrhea. This we all know, but endometriosis is more than these basic symptoms. So, adenomyosis is basically endometriosis of the uterus. So, dyspareunia and sexual dysfunction because of deep infiltrative endometriosis, they reduce the frequency of conception. Because of the chronic non-menstrual pelvic pain, they lose interest in arousal, in relationship, or overall emotional well-being. Now, this adenomyosis, it is called cousin sister of endometriosis because they always coexist together. Uterus is bulky and large, there is irregular bleeding symptom wise, and independently also adenomyosis is a risk factor for infertility and poor outcome in IVF. Now, what are the big questions? So, the big questions are why endometriosis affects some but not all women? What are the mechanisms that underpin the development of symptoms of varying severity? The clinical paradox, which I think we all must have faced, anatomy versus experience. You may find some patients which are having only mild endometriosis on the form of some 2-3 centimeter cyst on ultrasound. So, they may have a small cyst of around 2 to 3 centimeter on ultrasound, but they are having very severe neuropathic pain which is preventing daily functioning of life. On the other hand, you just open a patient or do laparoscopy for some other complaint and you find that she is having large endometriomas, distortion, but she never experienced any pain. So, that is the paradox of endometriosis. It means severity of disease does not correlate with the clinical manifestation. So, you never know when you do laparoscopy for infertility or endometriosis what you may find inside. Then comes the role of learning imaging by us, by clinician, because even the radiologist most of the time they are not that good in reporting endometriosis. So, we as clinician who are seeing patient and who are seeing inside the patient in operation theatre, we should know how to interpret radiology findings. So, we should have some idea about the ultrasound as well as MRI, because MRI gives a realistic picture of endometriosis, especially the DIE, deep infiltrating endometriosis. So, if we are prepared in advance for all the things which we may find inside, we can be better prepared for the better surgical outcome. From this slide, we should take this point home that the severity of the disease has no correlation with the symptoms. That is why this disease is heterogeneous. So, that is called a clinical disconnect. The staging does not always correlate. Some patients with stage 1, they are debilitated, and some with stage 4, they may are having a normal quality of life like us. As you all know from our PG times, we are just having this classification of ASRM. So, stage 1 to stage 4, as it is clearly visible in this diagram, minimal and severe. But again, this classification is very old and does not carry much clinical significance, because it does not correlate with the outcome, severity or the symptoms. So, when one classification becomes maybe less useful, then originates the another classification. So, we can be on the same page. Basically, what is classification of anything? Classification gives you a universal language in which you can communicate with your fellows, colleagues, your seniors, juniors, and basically we are all on the same page, and even patient also. So, basically this ASRM, it just a visual presentation for OT notes 1, 2, 3, 4, like we used to write in our PG days. Now, this EFI, it combines surgical finding with historical patient biology, like it includes other factors like age, years of infertility, prior pregnancies and other things. So, this has predictive value for pregnancy also, like if they are having a score of 3 to 10, so probability that there can be a functional impairment, but if they are having 9 to 10, it means they can have natural pregnancy or a better ART outcome. Now, the latest classification which was given in 2020, and we all are aware of that, that is NGN classification, which is a non-invasive and surgical description system for endometriosis. So, if you have to say in one line, NGN tells us where the disease is, while biomarker tell us how active the disease is. So, NGN is for the exact location of endometriosis. So, if we talk about NGN classification, I know it is little bit complicated because it has taken into account the peritoneum, ovary, tube and the basic structure like A, B, C, and the other finding like adenomyosis, bladder, intestine, ureter. Yes, it is very complicated to describe, but still it is of great clinical value, because on imaging, ultrasound, MRI, you can very well say that peritoneum, what is the peritoneum score, ovary, tube, these three part, the A part, the B part, the C part. The A part is rectovaginal, as you can see, the rectovaginal and rectocervical area. The B part sacrouterine and the cardinal ligaments, and C part is the rectum. So, 3 is the parameter here for the categorization into P1, P2 and P3. So, this is how full reporting, the non-invasive reporting of endometriosis is done, because it includes the ovarian endometriosis, the tube endometriosis as well as the deep endometriosis, that is DIE, that is the rectovaginal septum also, which is commonly involved in endometriosis, as well as peritoneum. This is a very normal slide, you all know it can be a peritoneal lesions, ovarian endometrioma or the DI, the worst, the deep endometriosis, which is sometimes not easily diagnosed. And the definition is the lesion which invade at least 5 mm. But some papers, they also refute this diagnosis because they say no, the 5 mm is not the criteria. Deep endometriosis can be anywhere irrespective of the depth. Now the pathogenesis of endometrioma, basically few years back we were only having a mental picture, means endometriosis means ovary, a cyst in the ovary, a chocolate cyst, that is ovarian endometrioma. But endometriosis is far more than the ovarian endometriosis. There are many other structures involved which we will see in the coming slides. So, how this endometrioma is formed? So, you see that this pink ectopic endometrium is deposited on the surface of ovarian cortex, then adhesions are formed and it becomes inverted. So, that is how the ovary invaginates and it creates a pseudocyst where the endometriosis develops. Now, this is a laparoscopy case of a 19-year-old girl. She was married with big endometrioma. So, you can see that nothing is visible, no uterus, no tubes, and just 2 bilateral large endometrioma. The patient was not symptomatic till 6 months. After marriage, she got pain and difficulty in having relation, and she went for ultrasound, and these were the picture inside of this big cyst up to the umbilicus. Coming to peritoneal lesions, we used to have that there are only brown, red lesion, but no, the peritoneal lesions can be white lesions, transparent foci, or they can be red powder burnt lesion. So, whenever you look for endometriotic lesions in laparoscopy, look for the various lesions. They can be black lesions like this, or they can be red lesions, white lesions, or they can be some transparent foci, but they all belong to endometriosis. So, these lesions, they do a long term collateral damage: infertility, chronic pain, mental health, quality of life. So, whenever a woman is coming to you with endometriosis, just do not think that she is having a chocolate cyst or she is infertile and the problem is solved. You may not know, and even she may not know what is she harboring inside, because imaging is never 100% true. So, please take care of her chronic pain, mental health, and quality of life, because endometriosis patients, they suffer a lot invisibly. If we talk about diagnostic pathway, history, examination and investigation. So, this DID, dysmenorrhea, dyspareunia, dysgenesia, infertility. This is the clinical parameter: imaging, ultrasound, MRI, but a negative imaging does not always exclude superficial peritoneal disease. Yes, laparoscopy is the gold standard. So, what this detect? The diagnostic modality, ultrasound and MRI, they are better indicator for endometriosis, and MRI is better in detecting deep infiltrating endometriosis. But still, if the radiologist is not tuned to endometriosis, they will not discover endometriosis, especially the small lesions. You very well know how to look for endometrioma on ultrasound. This chocolate cyst, how it appears like the typical ground glass echogenicity, this anybody can recognize. But the problem lies in detection of the deep endometriosis on MRI. So, MRI is for complex cases and deep infiltrating endometriosis. When you see a ovarian endometrioma and you want to preserve the ovary, or she is infertile, you want to do fertility enhancing surgery, better to order an MRI, because in MRI you can be better prepared for the steps you are going to handle. Like how this deep infiltrative endometriosis appears. These are the ultrasound finding, the transrectal ultrasound, and this is the TVS, full thickness of rectum. This is the rectum. So, using lot of jelly in the rectum as well as in the vagina, a good radiologist can very well pick the rectal nodule or the bowel lesion, like this is seen clearly, the bowel nodule, and yes, they correlate with the laparoscopic findings. So, what is this? So, this is the adenomyotic component of uterus, because endometriosis and adenomyosis, they coexist together. These are the lesions of the deep infiltrative endometriosis. Coming to advances in the diagnosis and management of endometriosis, a comprehensive review. This is the latest article. So, it is not same now. The future of endometriosis management includes biomarker based diagnosis, artificial intelligence guided imaging, precision medicine, and we are moving towards a single patient care. So, with technology we want to be less invasive. So, we can detect endometriosis early on the basis of biomarkers. So, what are these biomarkers? The CA125 has very limited specificity and sensitivity. The other markers, the genetic testing like enolase 1, vitamin D binding protein, cytokines and other markers which we just mug up the names. There are future research going on that it can be better in disease severity as well as treatment response. But yes, there is a great surge of biomarker going on. So, in future we can rely on this biomarker, even the salivary mRNA. So, detection of endometriosis is better in future, and not every patient has to undergo laparoscopy. Laparoscopy, you all know, it is the gold standard. Can you see these white lesions of endometriosis? These are the white lesions of endometriosis with some black component. The DI lesions, again this powder burnt lesion and endometrioma. So, as I was telling you that there are other endometrial antibodies and all these genetic tests which are going on, the circulating microRNA which are the biomarker for diagnosis of endometriosis. Now, this is my favorite slide because DIE is worst, dangerous for patient as well as for surgeon, because deep infiltrative endometriosis is like an iceberg. You are able to see just the surface, okay? Only the surface is visible to you, but see deep down what all is happening. There is neuroangiogenesis. So, if someone asks me what is endometriosis, I tell them in a medical language, it is neovascularization and fibrosis. So, that is why there is adhesions in surgery or complexity of the surgery. So, there is neovascularization and fibrosis. So, see all this is happening inside. So, there is depth of invasion, clinical translation in the form of severe inflammation, chronic pelvic pain, not only cyclic pain, because of all this iceberg model. So, please keep in mind whatever you are seeing is just the tip of the iceberg, and the various organs which can be involved in endometriosis is bowel, intestine, mostly rectum and sigmoid. So, we surgeon should be very clear about the rectum and sigmoid plane, how to dissect them and how not to injure them, and when to call our surgeon colleague for help. Vagina, primarily the rectovaginal plate, posterior vaginal fornix, the pouch of Douglas is obliterated, uterosacral ligaments, bladder and ureter. So, mostly they all have multifocal disease. So, this is how DI appears. Can you see this is uterus, sigmoid, rectum, all plastered together. So, this is the typical DIE. So, this was a case of a complete surgery because she was operated 2 times earlier for endometrioma, and then complete dissection of all the rectal nodule, bowel shaving was done. Coming to the spectrum of intervention, as you all know, supportive care, pharma and surgical. We as surgeons, we don't give much importance to the other modality, because a surgeon always wants to do surgery, and people who don't want to do surgery, they give medical pills. But it is not about the surgeon preference, it is about the quality of life of the patient and the need of the patient, what patient is desiring, because ultimately we are there to do benefit to the patient, not to ourselves. This you very well know. The first line is NSAIDs and analgesic. Then there is lot of literature on OCPs and Dynogest, GnRH agonist, antagonist, this Reluis, Relagolix and other things. So every things have pros and cons, and you never know which drug will suit to which patient. So it is just a hit and trial. Some patient may very well respond to OCPs, no need to give any other thing. Some respond to Mirena also, and some to Dynest. But people who are having very big endometriomas, severe pain, they should not be given Dynogest like candy, and their disease should not be allowed to progress, because the disease self propagates and definitely it will convert into DIE, damaging more and more pelvic organs. Targeted removal, we do lap excision of endometrial implants and cystectomy for endometriomas. Structural restoration, so whenever we go inside, we do laparoscopy for anything like fibroid or whatever adhesion. So our first aim is to restore the anatomy. In case of endometriosis, because of the neovascularization and fibrosis, this anatomy is so much disturbed, nothing is visible like I showed you in that picture. So our aim is to do the adhesiolysis, clear the anatomy, clear the scar tissue, the endometriotic spots, and restore anatomy so that there can be normal ovum pickup by the tube or fertilization and implantation. And if family is completed or she is in severe pain, the definitive treatment is hysterectomy only. We all talk about Dynogest too much, but we gynecologists should be very clear when to give and when not to give. It is not a replacement of surgery or an excuse of not doing surgery. So if you are having patients of endometriosis and DIE, please manage them effectively with your colleagues or refer them to an expert endometriosis center early, because the first surgery is always the best surgery, and many a times patients are operated again and again, and finally by an endometriosis excision surgeon. Now I got this term, the precision medicine, which I got to know when I was reading for endometriosis. So what is precision medicine? It means tailoring diagnosis and treatment to individual patient based on their disease phenotype, biomarker, genetics and their infertility goals. So it doesn't mean that one size fits all, so it is right for the right patient. So if I have to explain them into a layman language, so it can be that earlier we have ready-made clothes, but now we have custom stitched dresses. So we wear clothes according to our size, not that there is one drug and give it to everyone who is having endometriosis. So what the patient body needs, accordingly the medicine or treatment is tailored according to this lady's size. Okay, that is how we explain precision medicine. And believe me, as we are advancing in research, AI or machine learning, the precision medicine is coming in every era. That is precision medicine. You have to be precise with each and every patient. So what is the future of precision medicine? So we can preserve the fertility, stem cell redirection. So many researches are going on that we can use stem cell to block the recruitment of ectopic lesions, and they can repair the endometriotic lesions. And then there can be other things also which target prostaglandin receptor. So, this is all the scientist or chemical research, and maybe 5 year down the lane or maybe 10 year, we will find some effective drug which can really reverse this endometriosis. So, endometriosis is heterogeneous because the lesions can be variable, superficial, deep, variable pain, variable fertility pattern, different response, same treatment but different outcome. So, that is why this disease is called heterogeneous, different pattern, different response. So, coming to supportive care and long term. So, the management, it should not be just we are giving medicine or prescribing surgery and move to the next OPD patient. It has to be a multidisciplinary approach. There should be support in the form of nutrition, psychological care, and yes, recurrence strategy management, because endometriosis is a recurrent disease, often requiring long term monitoring. Early recognition is critical because that 7 to 10 year diagnostic gap will lead to permanent damage, and yes, it has caused much damage till now. Treatment should not be standard, and we should have a multidisciplinary approach. So, if you talk about the endometriosis patient, not only gynae, there should be pain specialist who understand their pain, because you have done surgery, you have removed the disease, but still she is suffering in pain. So, what do you think, is your surgery successful? Ultimately, the patient's symptoms should be controlled. That is why she has come to you, and you have to relieve her of her symptoms, not just the surgical outcome. The mental health provider, the pelvic floor physical therapist. So, it is a multidisciplinary approach. Coming to the endometrioma management. So, cystectomy or stripping, ablation or drainage. So, we all know that endometriosis should be excised, it should be removed. There is no role of drainage, ablation and all those things, it has to be removed. The recurrence rate is only 4% if you do proper cystectomy. But both techniques, they may decrease the ovarian reserve, especially if you are using lot of bipolar or lot of diathermy. Always do cystectomy irrespective of the size of the ovaries. So, this was a typical case of a bilateral endometrioma. She was a 30-year-old female. She was not having much symptom, although she was having this kissing ovaries and large endometrioma, but still she was not having many symptoms. She just had mild pain and she got an ultrasound done. So, there were large endometriomas and a cystectomy was performed. So, basically cystectomy is nothing, it is just traction and counter traction, and you should be able to identify the cyst wall and the normal ovarian tissue, and you just have to excise the cyst wall with a tooth grasper. So, there is a tooth grasper in my right hand and the assistant is also having a grasper. So, now this base of the ovary or hilum, you do not have to do lot of coagulation, burning or whatever. The oozing eventually stops and we reconstruct the ovaries. So, the other ovary was also involved and again the cystectomy was performed. So, what I want to say is how big the endometrioma, ovary need not to be removed, remove the cyst wall, do not do unnecessary cautery, just do cystectomy and suture with Vicryl 10, 20 whatever, improve your suturing skills and suture, because suturing gives two benefit. You can restore the anatomy and you can maintain hemostasis. You do not need so much of cautery, coagulation and damaging the ovarian reserve. Definitely AMH becomes low after endometrioma surgery, but still the burden of the disease is cleared. and the normal anatomy or hemostasis of the ovaries maintained. So, always and always remove cyst wall, suture ovary, give them a normal appearance. Coming to fertility and conception, I think everyone must have heard, do pregnancy and your endometriosis will be better. This is a myth. Pregnancy is not a cure for endometriosis. It does not improve symptoms or stop the disease progression. So, 60 to 70% of women with endometriosis, they can get pregnant. Not every woman require IVF. But yes, if they are struggling to conceive, they definitely should consult and get their fertility index checked. Then there can be assistance if they are not getting pregnant even after surgery or even before surgery if they are having mild endometriosis. It can be IUI or IVF. So, when to choose IVF? When fallopian tubes are compromised or there is male factor infertility. But somehow this endometriosis is multifactorial. Even if the tubes are patent, the microenvironment of female pelvis, the ovaries, uterus is very hostile to sperm and conception literally becomes difficult. Endometriosis can happen at any age from adolescent to menopause, and whenever a woman of any age group comes with such symptoms, never ever ignore her, because nobody wants to come to the hospital or to the doctor. They only come when they don't have any other resort. Okay? So, severe cyclic pain along with acyclic pain in adolescent, frequent absenteeism from school. In postmenopausal women, symptoms are there even after menopause. So, it does not mean pregnancy or menopause will cure endometriosis. So, always keep high suspicion. Then, as I told you in earlier slides, that it is a neuropathic pain. Earlier there was LUNA, uterine nerve ablation. There is a topic in our William gynecology books that LUNA has to be done, and I have seen people doing this uterine nerve ablation, but practically it has no role. Then there are other terms also, presacral neurectomy, but still it is also very complex to find the nerve plexus. So, for a DI, deep pain, excision is the only treatment. Coming to DI, the management of colorectal endometriosis. You must have heard about the three modalities: superficial shaving, discoid resection and segmental resection. As gynae surgeon, we will face the bowel nodule, the rectum nodule, but we should have that eyes and mind to diagnose that endometriosis. Sometimes we are just only bothered about ovaries and tubes and uterus. We don't see much else. So, we should have that vision that yes, endometriosis can be in the rectum, rectovaginal plate, POD obliterated, some peritoneal spots. So, whenever you do laparoscopy for endometriosis, try to have a holistic vision, not a tubular vision of just uterus, tubes and ovaries. You have to inspect every area. People have diaphragmatic endometriosis also, which is missed for 20 years almost. So, even many people ask me that how do you identify that this tissue is normal and this is endometriosis. So, there is a simple rule, elasticity. Okay? The tissue which is elastic, if it is normal appearing and elastic, it means it is a normal tissue. The uterosacral, the POD, sometimes the peritoneum is normal appearing, but it is not elastic. It has lost its elasticity. So, because of fibrosis, you identify endometriosis. So, the tissue which has lost its elasticity is endometriosis affected tissue. Coming to the superficial shaving, the indications that only the serosal, only the most superficial part of the bowel. So, you just have to do this skinning without opening the bowel. So, you have to be very superficial, but again it is a double edged sword. You have to remove the disease also, and you do not have to open the bowel also, because there is a thinking na, that if you have opened the rectum or sigmoid, it is a crime. No, it is not a crime. If diagnosed properly, you can repair it with the help of a surgeon. Then discoid, the lesions which invade the mucosa but less than 3 centimeter, you can do the transanal circular stapler excision. So, this segmental resection and this discoid resection, ideally they should be done with the help of a colorectal surgeon, because practically speaking it is their area, they are more into the post-op care and the other sequelae of all these surgeries. The complication rate is almost 20%, and sometime you may require ileostomy, colostomy, or there can be a anastomosis leak, which again has a very bad effect on the quality of life. So, as I told you, so the specialist role and responsibilities, the gynecologist, who is endometriosis expert, the reproductive endocrinologist, colorectal and urological surgeon, then the other people, the pain specialist, anesthesia, psychiatrist and pelvic floor physiotherapist. So, nurse specialist, care coordinator. So, basically to deal one endometriosis patient, you need that much of team effort. So, basically it should be a in totality approach. Coming to the post-operative course. So, there are high chances of recurrence in endometriosis. Why? Why some people have less recurrence, some people have more recurrence, even operated by the same surgeon, same caliber. Why so? Because the recurrence can be surgical factors as well as de novo lesions. So, basically this is the latest article of rethinking endometriosis from clinical challenge to biological opportunity. So, there are various mechanisms which are there for endometriosis recurrence, which are the factor which plays role in endometriosis recurrence. So, people think that the disease has recurred, it must be surgeon fault. No, it is not always the surgeon fault, because frequently framed as a surgical failure, rather as a biological phenomena worth investing time and research. The post-operative recurrence is common, like pain, which is almost 26% within first year, lesion reappearance, which is almost 29% after 1 or 2 years of surgery. So, the various factors plays a role in recurrence. It is not just the surgery. Again, this research that it is a systemic and complex disease, and we have to move towards the phenotype based classification and personalized therapy. It means precision medicine. Coming to the risk of cancer, endometriosis is not always associated with a high risk of cancer, but I would like to say that endometriosis is a benign cancer. It is not a cancer, but still having a benign disease, you have to do a radical excision of endometriosis, and patient does not die, but they suffer a lot. So, endometriosis is worse than malignancy. Cancer is visible, people get treatment, but endometriosis is not visible and not diagnosed early. So, if I want to conclude, early recognition, do not waste 7 to 10 years of patient's life for endometriosis diagnosis. We better be educated ourselves as well as the society, the patients, females, individualize the treatment, the precision medicine, and laparoscopy is gold standard, but again researches are going on for non-invasive diagnostic tools or biomarkers. So, basically there should be increased awareness among the healthcare worker about endometriosis, the women who are suffering from endometriosis, to improve the long term outcome And it would be beneficial for doctor also. Now, if patient comes early, you can treat better and you can feel good too. These are the changes in endometriosis research. It is not just a pelvic disease, it is a systemic inflammatory disease. The diagnosis, we can move from surgery to biomarkers and AI imaging. A hormonal suppression, if we talk about in journal, we can move to precision medicine. Surgery, it should be a complete excision by an endometriosis excision surgeon, and the care should be MDT, multidisciplinary care with personalized care. So, endometriosis is there, but if you can't see it, it doesn't mean that it doesn't exist.